but we welcome you for tonight's in-person or in in virtual event. I'm gonna, in a second, introduce our panelists for tonight. And before we get started, I wanted to give you just a couple words of introduction about Harvard Alumni for Mental Health, who is organizing this event tonight. Was created in 2014 and has taken a giant leap forward, started by the COVID-19 pandemic, when we realized that our membership might welcome a few events throughout the year. And in particular, being a community of mental health providers, a lot of us are interested in approaching the topics surrounding mental health from a lens of the clinical practices, the best practices, and discussing a little bit the experience that surrounds providing care for our clients in the community. So I would like to, with these couple words of introduction, turn it in towards the need that we have seen increase during the COVID-19 pandemic for an attention to survivors of domestic violence. We know that the stay-at-home orders have created increased danger and difficult situation to navigate for those who might be trapped in a situation where a perpetrator is around them without a way to escape. And we thought that this, in the honor of the month of awareness for domestic violence in October, was important for us to create an event to facilitate a conversation around this important topic. So as I let a few more people join in, I'm now going to turn the mic over to Charlotte Dowden, who is HUM's Director of Communication, to introduce tonight's panelists.
Hi, good evening, everyone. Thank you so much for taking the time and joining us. We have three incredible panelists here with us this evening. First off is Marie-Christine Nietzsche, PhD, but she is the president of HUM and a trauma psychologist. She earned her first PhD in philosophy from the Sorbonne University in Paris, France, before completing her second PhD in psychology at Harvard. And her clinical internship in neuropsychology at the Geffen School of Medicine at UCLA. She's a VA-trained clinician, and she works primarily with trauma survivors. Next, we have Gabriella Wells, LCS, and she is a bilingual and bicultural community advocate at the Second Step. She received her BA in psychology from UMass Amherst, as well as her master's in social work at Boston College. She's always had an interest in trauma work and has worked with survivors in several diverse settings. And her work specializes in a combination of direct service and community outreach, education, and prevention. And last but not least, we have Dr. Goodman. Lisa Goodman is a PhD, is a clinical community psychologist and a professor at Boston College in the counseling psychology program. She earned her bachelor's degree from Wesleyan University and her master's and doctoral from Boston University. In her work, she engages communities in research to develop and evaluate community-based responses to intimate partner violence. So we just wanted to say thank you and welcome again to you three for sharing your experiences with us tonight. I will turn the mic back to Marie-Christine. So thank you.
Thank you, Charlotte, for introducing our wonderful panelists. I'm very grateful to both of you for accepting our invitation and joining us tonight. I'd like to orient our audience to the program for tonight. We'll have a first section for the panel to share their advice about recognizing and supporting survivors of violence, followed by a Q&A section. Feel free to type your questions in the chat during the panel portion of the event if you wish. And then whether you would like to unmute yourself and ask the question directly during the Q&A portion, or if you feel more comfortable to text in a private message, Charlotte or I will be happy to relay your questions during the Q&A portion. Without further ado, I will launch an initial poll just to get to know you. We're going to ask you a simple question about who is joining us today. You should see that on your screen appearing right now. And we're going to leave that on the screen for just a second to get a sense and allow us to tailor our presentation tonight to the audience. Please let us know. Thank you. And so we have about an even proportion of mental health providers and mental health providers in training, as well as others in direct contact with survivors. And we have a bigger proportion of interested members of the community. thank you, everybody. That is helpful for us to know, and we'll be able to tailor our panel tonight to that. I would love to get us started directly with the topic of what abuse looks like. There are a lot of misconceptions, a lot of ideas floating around, and I'd love to turn to you, Lisa, and ask you, in your experience, what do you think mental health providers and members of the community who are interested in learning more about domestic violence need to have in mind about what abuse looks like?
Yeah, and thank you again for inviting me, and all of you for coming to learn about this topic. I always so appreciate interest, because it seems sometimes that it is marginalized in a strange way, given how commonplace intimate partner violence is. So I'm just going to set a big frame, and then I know Gabby has a lot to say about what intimate partner violence looks like, but I think that a confusing sort of mixed picture is clarified by this frame. Intimate partner violence, recent research has shown, Michael Johnson's done a lot of this research, can really be divided into two types, roughly, and it's sort of a continuum, and these are just very, very rough categories, but one is intimate terrorism and one is situational couple violence. So intimate terrorism is much more what you see in domestic violence programs and hospitals and clinical settings. And then situational couple violence is probably often in the general population. The main thing that distinguishes them is the idea of control. So in the context of intimate partner violence, partner is trying to exert dominance and control in a sort of patterned way, so that a survivor's fundamental liberty is really and physical violence doesn't need to happen that much for the harming partner to sort of gain and hold control. On the other hand, situational couple violence, more often found in the general population, is kind of like more of a mutually escalating process that eventually leads to usually less severe violence. Often it's triggered by an angry outburst and then escalates. So you'll see that intimate partner violence is more severe, it's more likely to cause injury, and it's profoundly more frightening and psychologically damaging than the other. Gabby, do you want to take it from there?
Yes, thank you so much. And just kind of piggybacking off what you said, that physical violence isn't necessarily of criteria that needs to happen in abuse. That's something that I've seen a lot in my work, that physical violence, although it is common, is not as common as other forms, but it's still viewed as kind of one of the more accepted versions and the other one's not. So with physical violence not being the majority that I'm seeing is financial abuse, digital abuse, spiritual and cultural abuse, immigration, and sexual. And in my opinion, and from what I have seen with the survivors that I work with, financial is one of the most impactful. I've spoken about this a lot, that money in this society is power. Officers are aware of that, and it keeps survivors stagnant in their situation when financial abuse is taking place.
Can you tell us, Gabby, a little bit more about what that looks like? You've mentioned financial abuse, you mentioned digital abuse. Those are perhaps new technologically mediated forms of abuse. What does that present like in your work?
Yeah, so financial abuse, how that usually presents is it's not as in your face as most people would expect. So what that really looks like is very manipulative, coercive communication and behaviors. So for example, abusers saying, let's share a joint account, it would be easier. I can handle the money, I don't want you to worry about that. It's very heavily guided in psychological and emotional abuse. And then in terms of digital, which is definitely a newer age form of abuse, especially with Zoom and cell phones and things like that. It's a lot of tracking devices, a lot of social media apps like Snapchat, those have tracking devices within them. So it's really accessible for abusers to have that. And a lot of survivors don't even know that their abuser may have access to those locations that they have.
Thank you, Yet, for providing those concrete examples. I remember one case, Gabby, at the second step, which is where you work, where we were working together. There was a case of a woman who had been telling the story that she thought the perpetrator was tracking her. And I know that in the first way the case was conceived, there was a lot of doubt around that. There was a lot of conceiving it as perhaps being a little paranoid or a little bit, worried, but without having great cause. And in that particular case, I remember that there was indeed a tracking device that was found in the car later on, thus providing a little bit, more of an objective ground. And the reason why I bring this specific example up is because, of course, when providers are working with survivors, there are things that can sound extremely far-fetched from the principle of you wouldn't expect somebody to do that. And yet in the context of control, we see even things that could sound far-stretched or harmless in other contexts become levers of the control that, Lisa, you were talking about, right? Things can be instrumentalized for the purpose of control that outside of this pattern would not have the same meaning or the same power over the survivor. I feel like we're rapidly moving towards all of these misconceptions or these ideas about what domestic violence looks like, what intimate partner violence looks like. And so I was hoping that together we can tackle a number of these myths about domestic violence. And you alluded to one, Gabby, just now by saying it doesn't always present like physical abuse. There are other aspects. And I think in talking to you, there is a point that you made that really resonated with me, is the impact that this stereotype has on survivors, the impact that society believing or equating domestic violence with physical abuse. How does that impact survivors of these forms of abuse, but also other forms of abuse?
Yeah, so I would say the biggest side effect of that is that survivors themselves often don't recognize that they're being abused. The standard is physical abuse, and law enforcement and legal systems still follow that oftentimes the only valid form of abuse is physical, or threat that it will be physical. And I speak with survivors that will say it's emotional, they haven't hit me, things like that. And it takes a lot of education to survivors saying, there's so many forms of abuse, and more times than not, the emotional, verbal, and psychological abuse is longer lasting and more severe on a person's life, more detrimental than physical. So that is a big we've seen. And for physical abuse to take place, more times than not, there's a long history of abuse that has taken place before that physical incident. Sometimes months, if not years, of abuse that has gone on.
Right, it's that slow but steady deconstruction of the survivor's self-confidence, of their support network, their ability to reach out, to reality check with others, all of these sapping work that happens, that takes place before the escalation to different forms of abuse. Thank you for highlighting that for us. Another myth that we often hear is, well, it only happens in certain socioeconomic areas. And what is that looking like in your experience? How is that myth holding up?
Yeah, so it doesn't affect from in more socioeconomic status than another. It happens in all, but the stereotype, as we know, is low income minority populations. And the only difference is the barriers and challenges within the abuse. So, we see that folks that have higher socioeconomic status, and it's usually not understood that happens in those communities. In reality, the challenges can be greater. For example, if you have a higher socioeconomic status, oftentimes survivors are intertwined in mortgages with their abuser, and that poses an array of challenges. Also, a big issue, like I spoke about with financial abuse, is that on paper, survivors may present to have high income, but don't actually have any access to this money because the abuser has control. And in turn, they don't qualify for benefits because benefits require a certain level of AMI. So due to that, it does pose a lot of challenges when it's higher socioeconomic status.
And how about perhaps the the word is escaping me. It's not social desirability, but the social pressure to maintain a certain appearance, a certain status in social situations. How does socioeconomic status factor into that in your experience?
Definitely. Reputation completely. People that are in higher socioeconomic statuses oftentimes feel that cannot leave due to status that they have in society and things like that. Of course, there's shame throughout all abuse, regardless of socioeconomic status, but the shame is presented differently with higher economic status, and it's more about reputation and their standing in the community.
Got it. Thank you. How about the presentation that perhaps providers who would subscribe to this idea that, well, massively IPV presents as physical, what are my cues, right? I should see bruises. I should see a very subdued survivor. Is that really the telltale sign? We're going to talk about this in greater detail in the second half of the panel, but as the first pass on this myth that DV means bruises, what's your take on that?
Right. Oftentimes, while I have worked with many survivors that unfortunately have had physical injuries present, the reality is that abusers are smart. Abuse is purpose, tactful, controlled tactic. So due to that, they know to not leave. Oftentimes if they're able to control that, marks and things like that are going to be able to be visible, because physical violence is more easily arrestable. It is assault, it is a crime. Whereas the emotional abuse that, presents, so to answer your question, so how that would normally present in those settings that providers need to be looking out for is, kind of those signs of financial abuse. If they have, mortgages or car payments, but they have no knowledge of things like that and don't really understand how to work those systems. Also, soft-spoken and low self-esteem and inquiring about certain things that can signal red flags, like questioning legal services and things like that. Those can be red flags.
Thank you, Gabby, for that. I know we'll spend longer time in the second half of the panel discussing for providers what to look for and how to intervene. One last myth that I know I've heard often enough is, well, it only affects weak people. It doesn't, if you're a strong woman, as the stereotype goes. I know IPV also affects men, and we're going to talk about the vulnerability for different types of identity, and in that case, the stereotype still seems to remain that somebody strong would not fall for that. Let's tackle this myth together before we move to the next topic for tonight's panel.
Definitely. Yeah, and that mentality, I think, oftentimes can be very victim blaming, to say, strong people won't fall for that. And, there's nothing that a survivor can do to allow abuse or fall for abuse. Like I said, it's a purposeful control tactic that abusers use. And it happens to everyone. It has nothing to do with strength or anything like that. It has to do with the abuser and their choice to inflict manipulation. And oftentimes, regardless of someone's internal strength and self-esteem, the point is that abuse, at least intimate partner violence, it's, inflicted by someone that build to love and trust. And due to that, they use that love and trust against the survivor. So, if you are a strong person and you are very compassionate and loving, abusers will use that to their advantage to, keep you in that mentality.
Yeah, we've talked, I know all of us have heard probably about gaslighting as being something that it's incredible the power that it can have. Just imagine when it's somebody who already has your trust, already has your affection, then the propensity to doubt yourself over the loved one comes into play in a tragic way. Thank you, Gabby, for spending a little bit of time, telling us about your experience with this different myth. I'd like to move to another topic for tonight's panel and to talk about the barriers to living, right? A lot of times the next question is, why didn't you leave earlier? Why doesn't she leave? Why doesn't he leave? We don't understand. And I'd love, Lisa, with all of your expertise, if you could tell us a little bit more to help everybody on this call and those who will watch it asynchronously to understand the complexity of the survivor's context. It's not as easy as just leaving. Tell us more about what's helped you wrap your head around that and that you can share with us tonight?
Yeah, it's an important question. We know, I think, at this point in the history of the movement that we're not supposed to ask that question. But I think that even, it's an honest one that even people who've been doing this work for some time continue to have, because sometimes the violence from the outside looks and is so bad and there is so much suffering. And so you sort of, in a sort of empathic sort of moment, why on earth isn't this person leaving? And sometimes when I teach my students about partner violence, I ask them to imagine their own relationships and, ask them to imagine, like, what if your partner is, screaming at you? Do you leave then? Probably not. What if they threw a sock against the wall? At that moment, do you sort of let go of the entire relationship? What if the sock went against the wall, but aimed at the wall, but hit you by accident? These things happen very gradually. And then finally, what if your partner hit you once, but by now you have a kid and a house, say? It turns out that it's tougher to give up your entire life by walking out than first appear from the outside. Sort of the people on the outside see the violence and not the context that makes it so hard to leave, just the violence that seems like one should leave. And then on top of all this, there's just a whole bunch of practical reasons why people don't leave. One is that enormous fear and justified fear of retaliation. Separation is the moment where very severe violence is most likely, and lethal violence, either as punishment for the betrayal of leaving, or in the spirit of, if I can't have you, no one can have you. So it's a very, and survivors know that. They know what it will mean to their harming partner if they leave. Obviously, economic constraints are huge. For many survivors, there are things worse than getting hit, which is being homeless on the street with your kids, or shelter that feels very scary. Leaving may mean the loss of childcare, transportation, the many resources that make life possible economically. And then, of course, more directly with children, there's custody issues. There's fear that their very charming seeming partner will gain custody of the kids and leave them with nothing. Not to mention that survivors may want their kids to have another parent in the house and want the sort of two incomes that other parent provides. This is in the situation of a survivor and a family. And Gabby started to talk about this. There's just so much shame, and they come from a whole different number of sources. And that is really something real and solid as the violence. There's the shame that comes from potentially violating cultural mandates, or community pressures, like the sort of religious mandate to honor your marriage vows, or maybe a norm that women's jobs are to maintain the relationship, or norms that you don't want to violate for fear of potentially being excluded from the community, and certainly feeling a lot of shame. There's gender roles. If you're a woman and your partner is a man, boys will boys, and it's a sign that he loves me, that he's so possessive and jealous. Men sometimes lose it. That doesn't mean anything. And then almost last in this litany, which will make you realize, I hope, that it's so hard to leave, the psychological effects of trauma. One of the ways that we all cope with a profoundly difficult or traumatic experience that is ongoing is that we narrow our focus to exactly what's in front of us, one foot in front of the other. It's sort of a biological move and a psychological one to keep us safe from all of the terrible things happening everywhere. 1 hour, after the other, 1 foot in front of the other. And that makes it really hard to put together the complex number of plans that would be required to actually leave. and harder still to navigate all the complex systems that might be required if you don't have resources to be able to leave. And then, well, second to last thing is that in line with this sort of trauma response, and Marie-Christine, you started to talk about gaslighting, but trauma almost always makes survivors start to distrust themselves. The abuser's narrative can become louder than the survivor's narrative, and the survivor, maybe, you know, the abuser saying it's not that bad, that this isn't abuse, that this is love, and the survivor can take some time to feel her way into her own narrative. And then the last thing is just that survivors often love their partners, and that's real, and hope that the partner will change. And that's not just sort of willful denial. It's that even though, again, us outsiders see this abusive person as nothing but a violent person or a coercive and controlling person, the survivor sees a much bigger picture. And she remembers the good times, and she tries to sort of foreground the good times, and is always hopeful that those times will sort of become more prominent. So basically, after all of that, you can see that it takes so much courage and strength and clarity and resources to be able to walk out the door. And it's sort of a testament to the enormous strength of survivors that so many do actually leave many times, because it often takes more than once.
Mm-hmm. Thank you, Lisa, for highlighting so eloquently these different facets, different aspects of the complexity. And I think that's what we tried to capture in the visualization on the flyer for this event, is this iceberg, right? That as a provider, as a person from the outside, you see the top of the iceberg, but you don't see the history of the relationship. You don't see the hidden social relationships, power dynamics, factors that are keeping somebody in this relationship. You don't see all of the roots of the abuse, because perhaps by the time you see it, it's reached a certain point, but it's taken a long time, and it's taken a cyclical nature. It wasn't a direct linear escalation into hell, right? And so this unseen part of the iceberg is actually playing a huge role. Lisa, you're helping us understand into the survivor's experience and their ability, cognitive, emotional, financial, social, to navigate the system out of the relationship. Gabby, I wonder, we're going to talk a little bit about the systemic responses, but I wonder if you can help us transition from, okay, the point of view of the survivor, and then when the survivor is trying to leave, what are some of the obstacles that they're facing at the systemic level, and then transition us into the different systems that a survivor has to navigate, so that as providers, we can be mindful of the different systems that, besides our relationship with the survivor has to coordinate with multiple other services and providers. Do you want to give us, sketch out a little bit that landscape for us?
Definitely. So exactly what Lisa was saying, that from the perspective of a survivor, so much strength to just even consider leaving and accepting that as an option. And once that, you know, is considered, there's so many barriers within systems that are set up for failure. And one of the most that I've seen recently, especially due to COVID-19, is lack of shelter and housing resources. One of the primary side effects of domestic violence is homelessness. And a big part of that is that there are just no shelter beds. Due to COVID, there wasn't a lot of movement. Shelters were very, worried to have new people come in, and people constantly coming in and out. And due to that, there's just no beds, and it's very far out within, for example, Western Mass, where there's a lot less resources that survivors need. Also, affordable housing. As we know, in Metro West Boston area, this is an incredibly expensive place to live. And unfortunately, survivors, they have to move further and further out. But like you were saying, kind of going into different systems, if the survivor, let's say, can't afford to live in Massachusetts because it's one of the most expensive states, and wants to move out of state, but now has a legal case for visitation with the and their child, they're not allowed to leave the state. So they're stuck in this system that isn't promoting any movement and not really empowering them to make those decisions that could provide a better life for them and their child. And it's important for providers to recognize that providers, need to take on the quote unquote burden of educating other providers and themselves so the survivor doesn't have to, because the systemic barriers also at its core is stigma. There's so much stigma within the systems, especially the legal system and law enforcement. Um, you know, physical violence is still really only viewed as a valid form of abuse. And I've seen times in court when judges and other lawyers and police will, say, oh, what was so threatening about it? Was it so scary? And there's nothing more invalidating than to say to someone that's come to that finally. So it's important to kind of understand all of those systems, how they're all involved in a survivor's life.
Thank you, Gabby. That's a perfect segue. I'd love to spend the rest of the panel's time to really dive deeper into, as mental health providers, as healthcare providers, what can we do, how to become a better trauma-informed provider? How can we be there for these survivors and help them? And I saw somebody in the chat asking, what can we recommend a survivor does to make it easier to leave? We'll circle back to that definitely in the Q&A. Can we, Lisa, I'd love to hear your thoughts about what are the first words you would say? I know you're very involved in training future mental health providers. Where would you start in that? How do we become a better trauma-informed provider?
Yeah, and these are some comments already in that and question in the chat. So I look forward to that discussion. But just very quickly, I would say that in a classically trauma-informed way, providers should assume that anybody who walks in the door might be a survivor, might currently be struggling. They're not necessarily going to announce it to you. But given the high rates of abuse among women, among gender non-binary and trans people, and even also among men, it can be, anybody can be struggling with it. And it doesn't always come up easily as something that somebody's going to sort of present with, for all the reasons that we talked about especially shame and distrust. And so, I have two recommendations. One is to stay open to the subtle signs, and that might be looking at how somebody talks about their relationships and various sort of kind of subtle power issues that might or sort of strange. I think, Gabby, you talked about economic abuse and sort of strange arrangements that people talk about. You might also look for, somatic symptoms, because chronic stress often shows up that way and is often easier to talk about that way. You might want to look at how people's sort of cognitions, like do people sort of get confused? Do they seem sort of gone, like dissociated at certain points? Are there gaps in their memory? I'm sorry, I'm just getting told that I have to re-sign up. I'll do that in a second. Are there sort of weird gaps in their memory which is also a symptom of trauma, also of head injury, which is extraordinarily high among intimate partner violence survivors who have physical violence in their histories, strange silences, and certain level of extreme distrust of you. All of those things. Another thing I know is also that there some clients you might feel are going kind of overboard in defending their partner from things that you're not even accusing them of, like they doth protest too much thing. So all of those are signs. So one is to just be looking for sort of biological, cognitive, and relational signs, like I just said. And then the other one is to just be very direct and really get in the habit of asking straight up all of your clients or the people you work with about whether they feel safe at home. And I think that if you ask that as a basic intake question, whether or not the survivor is ready to tell you, it sets the stage that like you're somebody that they can talk to. You're somebody who's not going to be afraid about this, who sees it, who knows something about it. So looking for subtle signs and then asking that question. And you don't have to feel like if you asked it once, you don't have to ask. You can't ask it again. You can.
Right. Really, I really value how you're embracing trauma-informed practice means realizing that trauma is not the exception. It happens at such a prevalence that it is recommended to take that into account in your clinical framework and to ask routinely that question, to open the space. Because by doing that, you're also creating an opportunity for that conversation, perhaps not this time, perhaps next time, for the survivor to come out and ask.
Yeah, it even a language so that later they might say, remember when you asked me if I was safe at home? Well, not fully. And then they've said it. And then it's a lot easier. It's like having words to get that over the threshold once they see that you're building your trust is really important.
Thank you. Yeah, and also, as you were saying, the multifaceted notion of trauma, right? That it might present as this cognitive fog, this slight confusion, this memory issue. It might present as an emotional or social withdrawal. It might present as a lack of trust. All of these are the different phases of trauma, and to be aware of it means that you're going to be more likely to pay attention to other facets if you start picking up on a couple of them. How about Gabby? I'd love to hear your thoughts on how one can become a better trauma-informed practitioner.
Yeah, thank you. And in also kind of responding to that message that came in the chat, in the same way, that I think we need to shift our mentality about helping survivors, in that it's not always the goal isn't always leaving. And I know that's not satisfying to hear, because of course we care about people being abused and we don't want them to be in that situation. But the truth is that survivors know what's best for them and their lives, and they already have everyone else in their lives saying, leave, you deserve better. So to have a provider saying that sometimes doesn't necessarily help in that moment. But focusing as a provider on harm reduction and safety planning, and making sure that they feel like saying in a safe environment that they can begin those conversations. Sometimes when providers go too headstrong onto, you need to leave, even if it's coming from a place of support and compassion, it can be very pressuring and can also cause survivors to retreat, sometimes not show to appointments anymore because they're not yet ready to make that step and they feel pressure and judgment from providers. So that's something, it's not satisfying to say we need to shift our mentality because we care about survivors, but it's more empowering to let them guide themselves in that journey. And as providers, we're simply, I like to use a kind of tour guide framework, that we're basically walking alongside these survivors and clients, pointing out resources and things that can reduce barriers in their journey, but it's their choice where they want to go. And we just go alongside them.
You said something that strikes me as important here, in the sense of something that therapists should be familiar with from other contexts as well. The goal is not to do in the place of the survivor. It's to empower them to build their sense of agency and to make resources available. Perhaps we talked about the cognitive burden of trauma and how it makes it hard to navigate these different systems. Perhaps to be proactive there, to ask about the different systems, educate ourselves, attend a webinar like tonight, to try and reduce the burden that is usually on the survivor to educate providers, to say, no, but you don't understand, here's what I have, here's what I'm dealing with. So educating yourself, respecting the survivor's words that they use to describe the situation, becoming aware of any cultural, I know we've talked about in Latina culture at Marianismo, and this idea of there's certain culturally relevant pressures that and norms and values that the survivor is bringing, to be mindful of that and try to be proactive in respecting wherever the survivor is coming from, in their own culture, in their own language, in their own readiness to take whatever action, whether it is leaving or something else, ensuring safety of the kid, ensuring other elements. I love your explanation of walking alongside the survivor and being there to help facilitate and help navigate and provide resources, but letting the survivor own their story and rebuild their power, their agency from that perspective. I'd love to talk about, well, you've probably already mentioned that a little bit, Gabby, and Lisa, I'm guessing you're going to agree as well. In line with that, survivors interact with a lot of providers for housing, for the kids, if there is a legal action, there's multiple detailed retailing of the episodes that might be relevant to a legal case. As providers, what would you recommend that we do? You know, we often take a detailed intake. How should we approach that in the case of a history of violence?
So in terms of, it's all about collaboration. I think providers need to collaborate a lot more and communicate with each other, of course, with the consent of the client, but building that relationship and learning what other services, your patient, client, whoever it may be, that setting that it's in, who they are seeing also can give you more of an understanding of who they are. If they're talking about DCF and they're talking about housing agencies, that's giving you a picture of the kind of a circumstance that they're in. And in that, you also, like you mentioned, Maria, it's important not to extensive retelling of trauma as much as we can, although it can come up of compassion that we want to hold space and kind of process that trauma. Sometimes it doesn't help, and recognizing as a provider when, you know, is it necessary for the survivor to be telling that, or can you be communicating with other providers to kind of get a full picture without them having to continuously retell the trauma they're experiencing.
How about, Lisa, when we are faced with these client stories, we are trained as therapists to hold a non-judgmental space. And yet it is by recognizing the emotions, the judgments, the values that come up in us that we can train ourselves to become better trauma-informed therapists. Can you speak a little bit about that conflict within the therapist assisting and survivors?
Yeah, this is an area where it's rife with opportunities to judge. And so I think it's just really, really important for us to be self-reflective when we're working with a survivor, you know, not pretending that we don't have any assessment of whether she's doing or he or they are doing the right thing or not, but to know those come up and then try to talk them through with somebody and not impose them on the survivor. And I would say, you know, judgments about the survivor, like whether they're leaving. And Gabby, I'm so glad that you said leaving is never the goal. And survivors in my research tell me over and over again that an enormous problem with the system they interact is that assumption is made and it does not match their desires. And then they just withdraw from the system. So it's really important not to make judgment if it's about what a survivor is doing or should do. I think it's also really important not to make judgments about the person who was doing the harm, because again, survivors tell me over and over again that, you know, they just think that my partner's a monster, and my partner's not a monster. I love them, him, them, whatever it is. And so it's just alienating when I see my therapist like recoiling. And so I think, again, back to, you know, why don't they leave? It's really important to hold that the violence is one part of a complex life. And I always tell my students that when you find yourself judging, that should be a signpost to you that you're not sufficiently in the shoes of the person that you're talking to. Like a judge, you know, nobody is simply causing their own suffering for no reason. It may be that other suffering that you're not aware of, that they're sort of trying to balance.
So to take that as a cue to investigate further, to be curious about what part of the picture you might be missing.
Well said. Yep.
Thank you. As we're continuing this conversation, we've got just a couple more points to cover. I will ask you in the audience to tell us if we're, you know, on target for this event. I'm going to leave that on the side. You can answer in your own time. We're going to cover just a couple more points, including very concrete recommendations for mental health providers. Now that you know that mental health notes in the medical records are open, and that your survivor, your clients may see them, but also if there is enough coercion or access, the perpetrator, the harmful partner may have access to these notes. And so recommendations around being mindful of what you put in your therapy note, in your clinical notes, because those reading it may cause harm depending on how it might be used, depending on who is seeing those notes. So being mindful of that, mindful of the danger of the perpetrator reading the medical notes and limiting the details, as Gabby and Lisa were saying, not just for danger management, but also for privacy and for the dignity of the survivors, right? You may very well capture the fact that there is a situation at home that requires coordinated care from the different providers currently involved in the care of the patient without having to give the details, the graphic details of the retelling that you've heard in session, right? So be mindful of that, and knowing that the notes can be used in different ways. And then I wanted to have two more points. One is because, Lisa, there is some updated research that in terms of referring a survivor of intimate partner violence to couple therapy, I know we say do it only with extreme caution. Can you help us understand why and where we're at just in a couple of minutes before we turn to the Q&A?
Yeah, just in a minute. There has been a very strong recommendation the last, several decades that one should never send where there's intimate partner violence to couples therapy. Never, 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 because one person has more power than the other, and that gets you never know what's going to happen after the session ends, and it's an opportunity for manipulation and furthering the abuse. In recent years, there are situations in which people think that we should, survivors want therapy very much, and that to be survivor-centered really means to listen to that, in some cases use it. The question is when. And so I just think a lot of supervision and consultation is required before you would work with a couple, two people as a couple in the context of violence, but that doesn't mean never.
Thank you, Lisa. It's important.
Yeah.
Important nuance to keep in mind. I know we're wrapping up. I want to leave enough time for Q&A. Gabby, you have a map of resources available throughout the United States. I know HUM is a global community, and so we're trying to have events that address the context of care in different regions around the world, because these different healthcare systems come with very specific context and recommendations. We're going to share tonight one map that Gabby is going to put. I think you have a link, or Charlotte can put in the chat for people to look at, that provides a lot of resources throughout the United States. And then know that Harvard Alumni for Mental Health is actively recruiting therapists, in particular culturally aware therapists. If you are bicultural, if you are practicing or were trained in a different culture in a different country, we have a lot of our community members who are asking, it's hard to find somebody who understands my cultural background, and I already have so much to explain. I don't want to have to explain yet again why in my culture this is accepted or this makes it difficult. And so Charlotte is also going to share in the chat a link for you who are mental health providers or mental health providers in training who would want to join this network. Please make yourself known to us. We have a lot of community members who are asking for these services, and we alluded to how important culture is in helping survivors. I'd love to open the Q&A for our audience to ask questions, make comments. I know we had a couple questions already, and those of you who have not answered the survey, I will leave it open a little bit more. Know that your feedback is what we use to determine whether we offer a similar event again in the future. And so it's very much community informed what programs we put out. I saw that there was a point about what would you recommend a survivor who is thinking about leaving to facilitate their departure? Gabby, Lisa, whoever wants to take that question.
Go ahead, Gabby.
Sure. So the question was, what can providers do to assist survivors in leaving?
Right, and recommend perhaps to the survivor to facilitate the after leaving. So perhaps if there's a legal case, for that legal case to be well prepared, and if the person who was writing the question wants to unmute and participate, feel free to unmute at this point. It's really open to questions from the audience.
From what I understand though, and I'm biased because I work at a domestic violence agency, but if you're not a provider at a DV agency, collaborating with one, DV agencies are wonderful and are designed to have multifaceted blends of usually legal, housing, and emotional counseling support for survivors. And connecting that and creating that space, like we said, leading with that, not leading with the expectation that leaving the situation is a goal. But if the person has already left and is looking for resources, it's all about collaborating. If they're talking about, they're worried because they don't know where they're going to live, collaborate with housing resources. And that's why, doing the research so you as a provider can lower that burden for the survivor is a lot better.
Thank you, Gabby. Lisa, do you want to add to this?
Yeah, I wasn't sure whether the question was, Anna, like if somebody's thinking about maybe going to the police later, what can they do to prepare now for that?
Yes.
Yeah. So yeah. And so I think that Gabby's point is that depending on the particular situation, a domestic violence program can really tell the survivor specifically what to do in her situation. But there's always things like telling a neighbor, making sure you take pictures, keeping a narrative, keeping your, this is sort of basic safety planning, but, keeping your most important possessions, your keys to your car, et cetera, in one place, well hidden, that you can grab and leave if you need to, even if not forever, even temporarily. But creating a trail of photos and narratives and other people knowing are really important for going to the police later, if that's something that the person wants to do. Does that address your question, Anna?
Yeah, it does, because sometimes people wouldn't go to the specific agencies because they don't want to, because they would be seen there or stuff like that. So sometimes, and I'm not mental health professional, so sometimes the only things you can recommend, it's like, at least keep evidence, because maybe later you change your mind, but then evidence in terms of photos may be hard because of digital control. So that was kind of where I was going to with this question. So thank you.
It's not easy, Anna. And I also want to just make clear that domestic violence programs are not just shelters. And that, like, I often, if I get a lot of calls from a lot of people, friends of friends, about, who are in violent relationships, and depending on where they are, I'll say, just give the Second Step a call. They'll walk you through options, or transition house, or reach, or there's a lot of, so they will just talk to you on the phone. You don't have to say what your name. And then if you want to, if your client wants later, or your friend, whomever you're thinking of, wants to go in for an in-person meeting, they can. But I think it's still kind of a misunderstanding in the field that domestic violence programs are all just shelters. But they can definitely consult.
We're lucky to have Gabby here in the call. Gabby, do you want to tell us a little bit more about what your role is at the Second Step and how you intervene in this chain of multiple services to support survivors?
Yeah, definitely. So this works out great because the Second Step is mainly an alternative to shelter, although we do have a residence. It's transitional shelter. It is for survivors that are transitioning out of emergency and need longer term in shelter. For a multitude of reasons. But myself, I don't work in the residence. I am a community advocate. So exactly what Lisa was saying, I work with survivors both ongoing and consulting, if they just call once, or family members can call, friends can call. And I work with them in an array of ways, whether that's safety planning to leave relationships or safely stay in the meantime of relationships, finding resources, whether that's housing. We also have a legal team that we partner with on a lot of cases. Most of my clients have legal cases with children, custody, things like that. So I thank you so much, Lisa, for bringing that up, because I do get that a lot, that it's perceived as just shelter, and understandably shelter can deter survivors. It seems very intimidating, but that's not the only thing that DV agencies offer. And we like to partner with outside providers. So, don't be, embarrassed if you don't know the answer to things, and you need to consult a DV agency. We specialize in that, and that's our job.
Right.
And
So
I just want to respond to because I know we have only, I hope that's how you pronounce your name, Ngozi. We only have a minute left.
Yes, I got it right. Thank you.
Okay, yeah. I noticed that both of you, your responses were about context, and I just feel like if there's any, you just sort of highlighted to what's most, I think, is the most important thing, that that violence sits in big context, religious and cultural and economic and love context, and I just can't stress enough how often I see people who maybe have not had a violent experience sort of thinking, oh my God, that's so horrible. That can't be, and sort of their own anxiety and empathy pulling them to sort of focus on that at the expense of everything. The very important cultural mandates, the very important other things that might hold a person in the relationship. So I just appreciate your naming those things. I didn't know if you had any other comments about that.
Yes, I really am happy to be part of this, because for those of us who are immigrants and of another culture, in our community before coming to the Western world, our community is pretty much community-based, in the sense that a village raises somebody. If you're married into a family, you're married to every member of the family. So you support more than we do here when we are just on one-on-one. So we experience a lot of abuse here at home when men or whoever the partner is not acting appropriately. You have the community that we run around, but once we started to westernize, we started noticing this violence a lot more. My sister was a victim. Eventually she lost her mind, pretty much that's what it is. And eventually she passed. And what happened, she was educated, she lived in the big city, there was nobody to talk to, no community around to talk to. Eventually she was able to open up to one of my brothers, and my brother's first question was, what did you do that made the man to be beating you? You must have done something that made it. Well, what did you do to get him to be sexually abusing you? Why, how can you say your husband is sexually abusing you? I mean, this is your husband that, so with that, it took her so much before she could even come out. And with that, she could not just process it. She withdrew, practically withdrew from everybody. Eventually, it affected her very severely. She started seeing psychiatrists and all the other. Anyway, eventually she passed. So it's a very painful experience for me, particularly because I can relate to the abuse very, very much. So that community is very, very important. If we can foster it, and there's one of you that talked about that it doesn't necessarily mean end of a relationship. It means empowering somebody to have a voice, empowering you to stand stronger than you are already standing, empowering you to to reject abuse, because we've seen that work in our community. We support the particular person, empower the person. There's even one that just the community got the man to actually leave the house for the woman. Eventually, the man moved back in, and they're very okay now. So everything doesn't have to end in like the relationship has to end. Community play a major, major role, in some of our areas, especially for those of us where our ways of life is very community-based, coming from Africa.
Thank you so much for that story. That is just incredibly valuable, and has so many applications outside that your particular sister's story. Thank you.
Thank you, Ngozi. Ngozi is the Harvard Alumni for Mental Health Director of Culture, Diversity, and Inclusion. And you can see how she's, of course, contributing, bringing all of these different aspects into this conversation that I think we've barely scratched the surface. It's a 1-hour event. I want to wrap it up here. If you want to stay a little bit longer, we will, but we're trying to hold our commitment to you who are attending that it is a 1-hour event. We would love, however, to continue this conversation with you. If you are interested in seeing more of our events, there's a newsletter. You can sign up with the Join Us form that Charlotte has shared in the chat. If you're a provider, you want to join this network of culturally informed provider that Ngozi is leading and helping bring to life together, feel free to let us know. I'd love to thank with all of my heart our panelists for tonight. Thank you for sharing your expertise, your experience, and helping us us both all become better trauma-informed providers. Thank you very much to all of you tuning in and attending. Have a great rest of your evening.